calcified and hypomaturation. More or less is during the enamel formation. As for hypoplastic, decrease in the enamel matrix formation. For hypocalcified, disruption in the mineralization process. And hypomaturation is actually deficiency in the final phase of the enamel mineralization. So hypoplastic, calcified, and hypomature. Okay, and then what are the plans for the child? When we see the child, what do we aim to do? Number one, of course, we aim to improve the aesthetic and function. And then we need to reduce the sensitivity of the affected dentition and also maintain the occlusal height. So if you work along the line of this manage what are the aim for the child, you should be within the good track of managing amelogenesis imperfecta. Okay. Okay, with the current nowadays, if you see a lot of trends in the literature review, they are looking into the quality of health, the impact, the psychological understanding of the children and the parents. Okay, being a clinician dentist, first thing that we do, uh, can I see your teeth? Can you open your mouth? Okay, before we do anything, try to understand what are the children and the parents are going through. What are the worrisome, the unknowing what the dentist will do, the expectations. Okay, so talking about the children first. Of course, the main issue will be aesthetic. They came to you, they refuse to smile, they are not happy with the color, they're being teased at, and size and shape of the teeth. Uh, Okay. In terms of sensitivity, some they cannot drink cold drinks and ice cream. Even in the worst ones, they'll be having problems of eating. Okay. And in terms of affecting self-confidence, the things that we get from the from the history of trying to understand what are the problems, they will explain to you that don't you brush your teeth? Some of the friends might say to them, uh, your teeth looks dirty. And others, and they sometimes they refuse to talk or they refuse to speak up in the class because they say that the friends can see my teeth, my dirty teeth. Okay. And they also are not confident because of their teeth. So they will just keep quiet, not participate in the class. In terms of the parents, okay, how do we understand them from this point of view? Some of them, they came to you with the guilt. They are very ashamed with what's going on because passing on an hereditary disorder to the children and future grandchildren. We do have cases where the parents and the child were in, but the blame games came from the child. Okay, the child blamed the parents for what's going on to their teeth. Okay, so be careful when you interact with them because these are the things that we didn't actually notice at first, but there's something going on that we need to help them. Okay. Knowledge here means that they want a sufficient knowledge about the disease. They want to know what to expect, what is our plan, and what is going on from the children until adulthood. Okay, so by having a knowledge about the disease, they can actually reduce the stress to the parents. And what do they want from us is actually support. What do you mean support from there? They want to be treated with respect. Okay, they don't actually know what's going on, but the way we explain the disease, the treatment plan they were about to, and what to expect is something that they consider respectful. Okay, and please, misdiagnosis. At the very first, sometimes this patient came to you with a poor prognosis of success. Okay, and then you end up saying, oh, they not brush your teeth well, you didn't clean, you eat a lot of candies. Okay, so that's why your sixes are very bad, needs to be taken out. But apparently they came with amelogenesis imperfecta. And another thing is insufficient pain control. Why is it worrisome for the parents? It's because you need to understand that when the parents bring their child to us, they come with the concept that the dentist will help my child. Okay, and if the child cannot tolerate pain, the parents can either react in two ways. The first one is either they blame the child. Okay, it's just a little bit pain. You should be able to uh, tolerate the pain. The dentists are trying to help you, but it's actually unbearable pain to the child. Or you are doing some a treatment for the child, and then the child is in pain. Oh dear, the dentist is treating my child badly. Okay, so please be very careful with the word insufficient pain control when you manage these children. Okay, and then fear of not getting the correct treatment. Okay, we have Mr. Google, we have Facebook, we have IG. So some people are saying this kind of composite works, that kind of crown works. And now we do have a lot of crowns coming in. I think a lot of new things coming in for treatment. Zirconia crowns will be quite expensive, but is it good for the child? It's actually going back to the cause and how it is. Okay, so this is basically what we need to understand from the children and the parents. Okay, all right. Clinical presentation. Okay, how does it appear? What do we expect from this kind of cases? Firstly, about the enamel defect, is an inadequate differentiation of ameloblasts that affect a position, mineralization, and maturity of the enamel. Okay, the enamel itself, okay, please bear in mind, it's very thin, soft, fragile, pitted, yellowish to brownish discoloration. Okay, it doesn't come in all, but it varies. Some are very thin, some has pitted, some has discoloration. Okay, and then it is very difficult to restore. Because of the structure itself, the fact, the strength of the adhesive bond of the restorative material. Okay, and then talking about sensitivity, because of the reduction in the mineral composition, that's why the child felt sensitive and have difficulty in eating. Okay, poor oral hygiene also is a main issue. They may come to you with gingivitis. Among the things that we get from the parents is that my child refused to brush their teeth well because of the sensitivity. And also because of the pitted enamel surface, plaque accumulated on that surface, especially if they don't get it well on the posterior region. That is why most of the time the posterior are affected. Okay. Okay. Next one would be reduced vertical dimension. Okay. What does it mean? It means that you can have a deep overbite because of the excessive tooth wear, or because of the structure itself, caries presentation is there, so that late detection, and then that's why you will get this reduced vertical dimension. Okay, but some studies have shown that other presentation can present as well. Okay, and then talking about psychological impact, if we look at the earlier slides on the children and parents perception, from actually what's going on is because of the early tooth loss. Okay, so late diagnosis, tooth wear, so end up with early extraction and then early tooth loss and affect the psychological impact. And apart from that, they will become embarrassed because of the aesthetic appearance. Okay, this is the very good clinical pictures that I get from Adorno Farias in 2019. They have hypoplastic. Okay, if you look at here, talking about defective the enamel matrix, and we have your hypomaturation, hypocalcified, both during the mineralization process, except for the one at the earlier phase, the other one on the late phase. And also there's a mix. Okay, apparently we do have hypomature, hypoplastic, hypocalcified, and hypoplastic. Okay, looking at this picture, my first thought, wow, a lot of variants, not easy to intervene. Don't know which one we should start first. Okay, I'm not sure how you are, but that's how I feel about these pictures. Okay. All right. So what are the challenge in managing this patient? There has been policies in terms of wait and see. Okay, what does it mean? It depends on different school of thoughts, different expectation, a specialist preference in managing the child. Okay, but the thing is that you need to consider is that inappropriate or too little treatment for the young patients may lead to caries, not because of the tooth structure itself, because of the oral hygiene as well and diet, but the tooth structure is not strong enough. That's why they get easily caries. And apart from that, the excessive tooth wear because of the soft and fragility of the enamel structure. So that's why they will have this reduced vertical dimension. Okay. How about next one is about extensive dental treatment. When we plan, the moment we diagnose these children, we need to understand if the presentation from primary tooth, so that it will be a long-term plan. From the primary dentition, you need to plan. From the permanent dentition, you need to plan. Okay, so it has to be an extensive dental treatment from primary to permanent. And then it will involve complicated treatment. You intended to do crowns, you need to do veneers, not just as simple as composites. So parents need to understand about this as well. And whatever you plan, it must be able to last until adulthood. Okay, so extensive dental treatments, although you have planned a lot of things for the child, you think that's the best for the child, by the end of the day, it always goes back to communication with the parents. Do they understand what you're going to do? Can they afford to bear the cost? How do they manage and take care of all this treat, feeling that have been done? Because how, no matter how good you are, when they came home and the child is not practicing a good oral hygiene, the same things will happen again. Okay, not talking about the tooth structure. I'm talking about the presence of caries, gingivitis, or even secondary caries because of the not maintaining a good oral hygiene practice. And the next one would be, it is a multidisciplinary care. We need to talk to our colleagues, the restorative specialists, the orthodontic specialists, because they will come with different challenge. I have one cases at the end. I will show you what the ortho colleague and I are facing in managing this patient, together with the restorative specialist as well. Okay, and then based on the literature review, amelogenesis imperfecta, what are the anomalies that has been associated with disturbance in eruption? Saying that based on that paper, they were talking about possibility of delayed eruption, congenitally missing teeth, anterior open bite, uh, deep bite, pulpal calcification, and so toroidontism. Okay, toroidontism, most of the cases happens in about 40%, so it's not a must have, but it may have about in 40% of the cases. Okay, all right. Okay, management. Okay, what do we need to do? How do we go about when you see this kind of cases? Okay, of course, we always start with history. Okay, this is what we've been taught from the dental school in the undergraduate program, postgraduate program. Begin with your history. Begin with a complaint. What does the patient want? What does the parents want as well, actually? Okay, they can say to you, doctor, my child is not eating well, having sensitivity. At the same time, the tooth looks dirty. I've been asking to brush, but the child cry when brushing. So you need to be very careful with the keywords that the parents are presenting to you. Okay. And then talking about medical history, there have been reported studies showing that amelogenesis imperfecta has been associated with other syndromes. They have cone rod dystrophy, epidermolysis bullosa, nephrocalcinosis, trichodento-osseous, Kohl-Schütte-Tonz syndromes. Okay, forgive me with how I pronounce it. I hope it's correct, but this is what I found in the papers. Okay, so if you have this checklist, so we need to see how the dentition is, because they usually associated with the syndromes. Okay, then you're done with the medical history. What next? Of course, your dental history. Dental history is something routinely that we should do. How about the brushing? How about the diet? Okay, so you need to understand what are the problems. Are they brushing good brushing habits? Are they using the correct toothpaste? And how about the techniques? What are the problems they are facing? Most of the time, they will end up saying that sensitive and brushing. Okay. And then going to the family history. So this is like I mentioned earlier, family history is very important because not just for the patient, it's because the importance of the early intervention for other siblings. When we understand the family tree of the disease, we can call in the other siblings and help with early diagnosis and management of the child. Okay, so that is about history. I hope everybody clears about history. It's quite straightforward. And then we'll talk about investigations. Okay, what do we do? Okay, uh, your normal routine practice, you do your clinical examination, your dental charting, your your assessment of the periodontal status, how's the gingival health, how the plaque score is, and then how about other investigation that you need to do. You can do your radiographs. It depends on your justification. What do you want to do? You want to take an OPG, you want to take a PA, or you want to take your bite wing as well. Okay, so your orthopentamogram, PG or DPT, is actually from there you will see this decrease in normal thickness, radio opacity, and as I mentioned earlier, prevalence of taurodontism about 40%. Okay, and then how about your your vitality test? Vitality test doesn't make much in AI, but it's actually because you have let's say going to Pro Policy 6. So you want to do your vitality test to see how it is. And from the PA, maybe you want to see any periapical lucency. Okay, so it has nothing much to do with AI. Okay, how about medical diagnostic? Okay, studies have shown that nowadays they are advocating genetic testing, but I don't think we do that yet here. So these are among the genes that are being tested for AI, and also presence of higher serum bone alkaline phosphatase and lower growth hormone levels. Okay, so this is basically what we do. We see, we understand the history, we investigate, and then we come up with the diagnosis. Okay. Okay, so these are the medical, the associated syndrome with amelogenesis imperfecta. You will have your Cone rod dystrophy. Um, please don't ask me how I read this. The retina, I'm not sure. This one based from the online. They were saying that this is normal retina, this is the Cone rod dystrophy. It's actually inheritance eye disorder, causes vision to be lost. And these are the cases that we normally see in our clinic, epidermolysis bullosa, easy blistering of the skin and mucous membrane. And also we have this, trichodental osseous. It's actually an autosomal dominant, belongs to the group of ectodermal dysplasia that affect hair, teeth, nails, and our skin. Okay, just to share fun facts. Um, I think ectodermal dysplasia, they have very little hair, but for trichodontal osseous, they were saying kinky and curly hair, which I don't know how, but this child present with straight hair. Okay, and then the other one will be Cold-Shooter-Thorne syndrome. It's actually a severe global developmental delay. The child presents with seizures and spasticity, and they clearly stated there amelogenesis imperfecta as part of the dental problems for this syndrome. Okay. Okay. All right. Management about treatment. Okay. What are your plans? What do you need to consider? What can you execute for the child? Okay. First, what are your plans? We need to identify the risk. This is going back to the other siblings, not the patient itself, but will help the management of other siblings, risk identification, early diagnosis, and follow-ups, okay, so that we can see early what's going on. You need to consider what are the remodelization agents that you want to use, the home use or the professionally applied in the clinic. And then what are the caries prevention that you want to use to advocate for the child. And how about your restorations? You can go from, depends on the cost, like I said, composites or up to the expensive treatments such as zirconia Even middle range, you can go your stencil crown, your strip crowns, okay? The normal routines that we've been using. And also please review the patients because we need to maintain the child in a very good oral hygiene, okay? So what do we do in preventive and initial phase? Your routine oral hygiene instructions, your fluoride regimes, prophylaxis, and okay, as for prophylaxis, okay, please do consider the amount of pain or the expectation of pain that the child will be suffering. The very severe one of amelogenesis imperfecta, even with suction itself, the patient will be crying when you do any treatment to them. Okay, so be very cautious of how the child is. And then apart from that, we need to talk to other colleagues as well, your multidisciplinary discussion at the beginning of the treatment. Like I said, restorative colleagues, your orthodontic colleagues, okay? And then your restorative phase, okay? Whatever it is, communicate with the parents because first thing is you will plan the best treatment for the child. I'm sure everybody will be. But however, you need to consider how the patient is. Can they tolerate your treatment plan? And how about the parents? Can they bear the financial implication of the suggested treatment? Okay? And how about the maintenance phase? Of course, monitor the oral hygiene, periodontal status, and how about the pulpal health, and also the quality of the restoration that has been provided. Is it still there? You're planning to do you did your composite restoration. 1 week later, your composite is lodged. Okay, that is something that you need to understand because of the bonding. Okay. Okay, so we have your plan. You already have your map in plan for, you have your game plan for the child. What do you want to do? What do you need to do? And then now you need to consider what are the things that I need to be aware of before executing the treatment. Okay, first is your size of the pulp chambers and the amount of the occlusal and interproximal tooth wear. Okay. Uh, the saying that the extent of the tooth loss and also the closeness to the pulp chamber is something that you need to consider. And loss of the occlusal vertical dimension and the degree of the dental-alveolar compensation. Do we need to increase the vertical dimension? Do I need to do something with the posterior tooth to increase the vertical dimension? Do I need to provide any appliances to help with that? Or I need to do the crown slightly higher of not just the tooth itself, but the dimension, the vertical dimension of the dentition itself. Okay, then focus specifically to the tooth. How about the numbers? Is it missing? Is it more than enough? Okay, we're going back to congenitally missing or even supernumerary tooth. Okay, and then how about the form? Talking about the shape, the sizes, smaller shape, because of is it excessively worn down, so it's very small. Okay, and then color. Okay, color, be very careful. What do you plan to do? It depends on the quality of the enamel of the dentition. Okay, and then sensitivity of the affected permanent teeth. You can't do much if you don't control the pain. Most of the time, the child will be screaming at you. Okay, that will be the tooth itself. Okay, now talking about strength of attachment of the enamel to dentin and the dentin quality. This is going back to is it hypoplastic? Is it hypomaturation? Is it hypocalcified? And apart from that, you can see the extent of the enamel to the dentin itself. And then thickness of the enamel and the degree of mineralization and the ability of restoration to bond satisfactorily to the affected enamel. Okay, like I said, there will be an issue in terms of the adhesive bond to the structure. Okay, so these are some of the recommendation on the based on the literature review. The treatment, okay. Just now I mentioned earlier about the color, right? The child was not happy with the color. You can do your microabrasion with your but however, you need to understand it can reduce the discoloration, but it's not suitable for soft enamel. if something that as simple as using a probe, the enamel is easily pricked off, then that is very soft and fragile enamel to begin with. Okay, they do have recommendation as well. For hypomaturation, you can apply bonding directly to the dentin, not to the enamel. And for hypoplastic cases, you can do your normal acid etch composites. As for hypocalcified, however, they're recommended to use sodium hypochlorite to improve the bond strength of the restoration. Okay, so it is as it is, not as easy as it seems. Okay, okay. These are the some available treatment options. I'm just showing you all what we have. Hashtag I'm not intelligent. So we do have your composite veneers, your components or U veneers. It depends on your preference, what you want to do, how you prefer. And you will also have your celluloid crowns for primary tooth or permanent tooth as well. And as for your molars, you will have your polycarbonate crowns, but I think the polycarbonate crowns comes with from the anterior to the posterior teeth. Okay, but my experience with polycarbonate crowns is a bit too bulky, and uh, it's not as easy as it is to place these polycarbonate crowns. But then again, it depends on the hands of using it. If you are very good with polycarbonate crowns and it's comfortable, then might as well just use it. Depends on you. Okay, I do know some people very fond and keen with the zirconia crowns. But then again, like I said, the cost will be an issue. This is something that you need to discuss with the parents about the cost implication. Okay, and then talking about yes, our bread and butter of pediatric dentistry would be our stainless steel crown, either on primary and permanent. But for those who are not familiar, please be very careful because putting a sensitive crown on permanent tooth is not as easy as is compared to the primary tooth. Then again, it depends on the hands of doing the treatment. Okay, so these are the some of the available options, but I'm sure there are more. Feel free to try to find more, but this is among the things that I've stumbled upon during my readings. Okay. Okay, so sharing for clinical cases, this is based on what I've been doing. What are the cases that I've seen? Okay, case number one. Okay, this is a 10-year-old girl that came to me. On the very first, she refused to smile. It would not be easily to get her smile. And apart from that, the mother did inform that she has sensitive at the back tooth. Okay, during that time, she doesn't have any medical problems, but she has full oral hygiene. Okay, so so if you see this picture here, apart from the crowding as well, you will see that full oral hygiene, some caries here and there. And what happened to the sixers? Uh, uh, this is the part when I say some of some of us. No. I mean, you can misdiagnose saying that full prognosis of success in this kind of cases because the child is not brushing well. Okay, and it's actually, if you look in the OPG here, you can see the tooth structure. Especially if you look at the 1-7, you can see that even without eruption, the tooth structure is already defective. Okay, and more or less, my problem with this case was the extensive of the sixes here. Okay, and also the other structures as well. Okay, so what we do is our treatment objective was to improve the oral hygiene, of course, coming regularly, asking to brush, and eventually she improves, of course. And then the aim was to restore the carious teeth and provide some aesthetic for the child. And then what are the challenges that I faced when managing these cases? Of course, um, although she's 10, but it's very stressful to give her LA. She'll become stressed. Not just the clinician is stressed, even the child is stressed with me by giving LA. And of course, sensitive when drilling. Um, okay. And then, yes, like I mentioned earlier, poor prognosis of success. But this case, I don't have the post-op pictures, but if I'm not mistaken, we end up with Stelsey crown on the sixes, and we do some composites fillings and improve oral hygiene of the child and continue to monitor. Okay, this is another case. Okay, this is a 13-year-old girl that came to us early. Is because of the older brother was treated with the same problem. So this is why I say that in amelogenesis imperfecta, it's very important to understand the family tree because then we can refer the patient earlier. So the older brother was treated by previous clinician, and I treated the younger sister. When she came to me, it was not that bad, and she doesn't have any medical problems. Her hygiene was quite fair. If you see here, she has this pitted enamel. Okay, the structure looks better, but the pitted enamel is here, so she has a lot of plaque accumulation. You can see some gingivitis here, and also the sixes carries on the sixes, and um, we put some temporary filling here. Okay, so what was the aim for the child was to improve the oral hygiene, restore the enamel defect, and our challenge was the aesthetic work. To put crown or not to put crown, to put composite or not to put composite. Okay, so like I said, aesthetic work is a challenge in managing the amelogenesis imperfecta. Okay. Uh, okay, so this is my last case of the day before I wrap the sessions. This is a very dear case to me. The boy has been currently the boy is a 15-year-old boy. She's been under our care since 9 years old. I've been working with my postgrad as well, and also these are the case. Okay, when the boy first came in, he was referred by GP for extraction of full prognosis of sixes. Uh, the letter was intended that the child was uncooperative for extraction. Okay. However, when we see the child, okay, uh, this is very interesting case for us because when we do the family tree, it's a sporadic case. It's not from the parents, no other siblings have it. And based on the mother history, none of the other family members, extended family members, are having this problem. And what puzzles us at the beginning was the primary teeth was much better than this one. But the moment the permanent teeth erupted, it appears like this. Okay. So for this case, our problem list was he has a congenitally missing of one tooth. There's nothing here, if you can see here. They're just straightaway canines. Okay. Hence, going back to the earlier slides that I mentioned, among of the things associated with amelogenesis would be congenitally missing tooth. The ones that have been referred to us, management of deep caries, enamel hypoplasia of the sixes. So we did a Stelsey crown. And then at the beginning of the earlier, when the child came early, there was supernumerary at the palatal of the 6-1 and 6-2. And then extraction was done. And unfortunately, I think this has not been associated with AI, and I have not seen any case reports. The child present with dentigenesis here at the area of 2-5, and surgery was done to remove. And now for this area, he lost 2 units, so he doesn't have 2-5 and 2-2. And apart from that, he has an impacted of 3-3. Okay, so based on the pictures, this is the presentation now. To tell the truth, it's not easy managing the child. With suction, he screams. Of course, the triple air, and of course, most of the time he was quite angry because of the sensitivity. Okay, and Stelsey crowns was done, but all this was done under GA. Okay, so no crying under GA. You can see here he doesn't have both laterals. Missing of the 2-5 here. This is a 2-4. Okay, so this case in managing the canine, we refer to the auto colleagues. Okay, among okay, my colleagues, Dr. Mushida, I'm very grateful that she take up this case together with our restorative specialist, Dr. Gu Ling. The first impression that I got is that, okay, first, the child is uncooperative, of course, because of the sensitivity, but they were having problems to bond the brackets. Okay, because of the structure itself, you cannot easily bond the bracket here. So they need to do a build up. So our restorative colleagues together with Pete did the build up on the premolars, okay, but some, but they do come out. I mean, not the filling came out, the brackets came out, okay. So this happened quite sometimes, on and off brackets dislodge. So so what we end up to do is that we only managed to bond fixed appliances on the upper dentition. We didn't even manage to do the lower because of the structure itself, and also even with the upper large to surface, the bracket still dislodged. So the plan was to create a space here on the laterals, later on to replace with prosthetic. And one of the another problems that we encounter in managing the patient is the fluoride regime. Okay, I have read up. Okay, what we did was we apply. Unfortunately, we apply SDF, silver diamine, and for those who are not familiar, um, cannot be done for enamel defect patients, because what happened was you have stainings and it's difficult to remove the stainings. Okay, so among the things that I've learned in managing this patient, the rest I think should be okay. So this is saving the last for the saving the best for the last. Okay. So what are the take-home message for today? Please, okay. Managing AI will depend on the age of the patient, on financial resources, the type and severity of the disorder, and also intraoral condition at the time treatment is planned. And the important thing is to understand the impact of the children and the parents, and please do communicate with them. Okay. Uh, these are some of the references. Okay, before I end my sharing session today, just to preview our next MAPD webinar, please block your calendar. We will have another ones on 12 August, on Wednesday as well, same date, same time, 1 to 2 p.m. It will be given by our invited speaker, Prof. Dr. Eswara Umar. She's the head of Department of Pediatric Dentistry of Malacca Manipal Medical College. And she'll be talking about pulp therapy in primary teeth. And this session will be moderated by our wonderful president of MAPD, Dr. Joanna Bahadun. And please do enjoy us. Please do join the session. With that, thank you everyone. Okay, I'm reaching the end of the documents. Going back to, okay. Sekejap ya. Stop sharing. I think Dr. Anna will take over the sessions. Anna, you still here?
Yes, I'm here. Thank you, Dr. Farina. That was a really enjoyable session, and I think we've got a lot of burning questions. So I'm going to try to do this as fast, because I know some of you have to get back to work. So yes, I think Farina will just get on with some of the questions. I've got a question here from Sharifa Nuratika, asking to elaborate a little bit on the dental-alveolar compensation that you mentioned.
Okay. Okay, the dental alveolar compensation is actually you were talking about about the vertical dimension of what you need to do. Okay, so because of the early caries, and also because of the enamel itself is quite fragile, so you have this extensive tooth loss. So if you from my I think case number 3, if I'm not mistaken, we will have a quite deep bite on the child. Okay, so but uh, you need to understand what are your plan for the child. You want to increase the bite by when you place your crown on the posterior teeth, Do you want to place it slightly bit higher so that you can increase the bite, or you can plan for any appliances to just to increase the bite so that you can help with the dental alveolar compensation. I hope that's answer and within the correct
Yeah.
understanding.
Yeah. Yes. Okay. There's also been a couple of questions. I think some of them have put up with regards, because I totally understand this is with regards to the bonding. So I think there's been a question to just get some explanation, because you mentioned that for hypoplastic, if you use sodium hypochlorite to increase the enamel bonding, so that's one of it. And I think the other questions are also for bonding. I think how to increase and how to manage, because I think Dr. Habiba has also mentioned that, especially for anterior teeth, he has a lot of issues with getting her restorations to stay on.
Yes. Talking about sodium perchloride, uh, y- there are papers recommending to use, but to be honest, I still have to do my homework to see what are the
Yeah.
consideration because I haven't tried it before. So far, with my cases, I usually end up with crowns. With the ones that end up with the composite, usually on hypoplastic cases, so they can tolerate the SEH composite.
Mm.
But you can, it has been recommended to use sodium chloride, but if I'm not mistaken, you maybe about two. I'm not sure. I can't recommend yet what are the concentration, but they do works to help with the bonding of because they remove the layers so that I can easily bond to the dentin.
Okay. Um, okay, now if a patient comes, so this is an interesting question, because this is from Tengku Nur Farhana, and this is regarding how you would manage a patient during our current pandemic and COVID and everything. And usually they're going to come in with pain and things like that. So is there anything just as an intermediate sort of treatment, because you may not be able to get down to business as usual? So is there anything different that you would do or recommend for management of these patients during COVID?
Okay. What was done on the on my patient? One of the patients was we we prescribed with STF. Apparently, together with my postgrad, it helps with the sensitivity. So the STF does reduce the sensitivity of the patient,
Yeah.
but it comes with a
Mm.
price. The end up was we have a blackish appearance on the lower anterior teeth. Even the mother and the child was not very happy, and they were asking
Mm.
what's going on with the child. So there's a way between helping with the sensitivity and also what we end up. But I would recommend that you all try with the normal fluoride regime first. For example, your Durafat application or your even your tooth mousse, because those are the
Yes.
things that will not cause stain to the teeth compared to SDF.
Yeah. I think you've just answered the next question by Junning, who's also asked, not sorry, not Junning. I think we had an earlier question. Michelle said, would you use fluoride varnishes and tooth mousse, and which is you have already addressed that.
Okay.
Okay. Yes, I think Junning's question was regarding how do you differentiate AI from MIH apart from history taking? So
Okay. Yes, AI and MH. Going if by the book, by definition, of course, MIH only involves your incisors, your molars, and also your deciduous molars. Okay, but as for AI, involves all the dentition. Okay, and then the presentation was, like I said, it's not that straightforward. Some cases present, especially in hereditary cases, they will present from the primary dentition. But if you do come up with sporadic cases, like we want, like I have earlier, it happens in the permanent dentition, or maybe it does happen in primary too, but because it's already have extensive caries, so that's why we didn't manage to get it early. Uh, by definition, MIH only involve that tooth, incisors and molars. By AI, is a generalized affecting the dentition.
okay. There was another question from Emma. I think Emma suggests, I don't know whether it's your real name, sorry, I'm just reading off the, okay,
What name
whether
again?
you suggest alternative use of deproteinization agent instead of sodium hypochlorite. It's quite an interesting, yeah, suggestion as well.
Okay. Something that we
Yep.
both can look at it.
Our next topic of research.
Yes. Let's go,
Okay.
Emma. Do PM me.
Okay, and just a message to those of you who are still in the group. Please do sign your attendance, and we will try. I know some of them probably had to drop off earlier because they had to get back to work. But do also send us in maybe to the MAPD email if you have any suggestions. So I just want to remind you to sign your attendance. Um, I think I'd also like to say thank you. I think it's been a really good session. Um, and being the first session, of course, there are some hiccups. I think some people couldn't get in. We at Exco or at MEPD, we promised to look into this so that by the next session with Prof. Umar, we will try to get either 500 or unlimited participation. Thank you so much for everybody's support. And I think we really need to move forward after this, knowing that we have so much of support. We will definitely invest in something so that we can bring it to you on a different platform. I want to say thank you once again to Dr. Farina for allowing yourself to be the first person for this session. And I think we're going to have a great next half year till December for all the other lectures that have been scheduled. So again, please do follow us on Instagram, on Facebook, and a very big thank you to all the participants. Thank you so much for joining us here today. We will try to get, for those of you who have asked, we will try to get the recording onto Facebook. So do like and follow us at Facebook. And with that, I think we've come to the end of this session. Thank you once again, and hope to see you all on the 12th of August for our next session. Thank you.